Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And a very good morning. Rise and shine, everyone. So welcome to the IMMB Faculty of Medicine webinar on Dengue Symposium entitled Dengue Management and Diagnosis, Update and Challenges. First and foremost, I would like, on behalf of the IMMB, as well as the Faculty of Medicine, I would like to extend our gratitude to both speakers, Dr. Saiful Muhammad Sani, as well as Dr. Jeyanthi from IMR, to be able to share and provide us an opportunity with their expertise in managing dengue, our long-time buddy. Yeah. And not to forget to all the audience who are actually taking at least 1 hour out from their busy schedule to have to share to listen to both of the experts here. One is from the clinical aspect and the other one from the laboratory aspect. So without further delay, allow me to introduce both of our speakers. Our first speaker is Dr. Saiful Safuan Muhammad Sani, or I call it as a 3S. It's very unique. Saiful Safuan Muhammad Sani. He was actually my previous MO when I was in HKL. And he's currently a consultant in acute internal medicine in HKL. He had his MBBS in the year 2000, followed by MRCP in 2007, and gazetted as a specialist in acute internal medicine in 2015. Apart from that, he is appointed as one of the panelists in Institut Kesihatan Negara as a committee members in subspecialty of acute advanced internal medicine, fellow in mortality meeting for dengue and malaria at the national level, as well as expert reviewer for health technology assessment on integrated vector management for Aedes control. Apart from that, he was invited for various talks in seminar and conference and published almost 50 publications, including journal articles as well as abstract. So we move now on to the our second speaker, Dr. Jeyanthi. Dr. Jeyanthi is currently served a virology unit in IMR and RH. She is microbiologist who graduated or completed her PhD in 2019. Her area of interest includes microbiology, vector-borne disease, biomedical research, molecular biology, infectious disease, and molecular genetics. She had secured more than 10 international and national grants and had published more than 50 articles and abstract. And apart from that, she also served as a proposal and manuscript reviewer, as well as an active researcher, as well as scientist. So without further delay, let's welcome our first speaker, Dr. Saiful Safuan Muhammad Sani. Yes, Dr. Saiful, the floor is yours.
Firstly, thank you very much, Dr. Fadzilah, for the kind invitation. So let me first start sharing my screen. All right, can we all see that?
Yes.
Yeah, okay, right. So effect, the topic that was given to me is effect of comorbidities on the outcome of dengue fever. I think it is a challenging aspect of clinical management of dengue fever. Now, first and foremost, I think it's important that we appreciate that dengue in endemic countries such as Malaysia is, for the fact, for the word endemic, is truly prevalent in Malaysia. If you are Malaysian, if you reside in Malaysia for more than a couple of years, you're bound to get dengue in your lifetime. So from this study from IMMB Institute of UKM, you can see that by the age of 45 to 50, 90% of the population would have had dengue in their lifetime. So it's just that the remaining 5 or 10% would somehow or rather manage to avoid dengue because probably they reside in the rural areas or deep in the jungle, such as places in Sabah and Sarawak. Now, I would like to do a few things in this talk. Firstly, I shall overview the clinical management of dengue. I think it's important for anyone, both clinician and researchers, to appreciate that at the end of the day, the reason why we research dengue is because we would like to treat patients. There's a lot of clinical management that needs to be studied and explored. So I'll do that first so that all the researchers here are well versed or at least aware of the current situation of clinical management in dengue. And then I'll go straight into the topic that we are going to address, the comorbid illnesses and how it affects outcome in dengue. And specifically, I'm looking at how the comorbid illnesses modifies this, the cause of dengue in terms of the severity of the illness and finally mortality. In my talk, I hope you all, the audience, will consider what are the quality and knowledge gaps exist within the literature that I shall present. And finally, I like to suggest that the role of endothelial glycocalyx in dengue and also in the comorbidities that comes with dengue. Now, the current classification or stratification method that we have for the moment is from the WHO World Health Organization guideline that was published in 2009, and we are still using it in Malaysia. Our CPG are based on this guideline, WHO 2009, and it stratifies into 3 tiers: severe dengue, dengue fever with warning signs, and more common majority of patients who have dengue fever alone. Now, this type of classification bodes well to clinical management because one more thing, I like to also stress that what people might miss is that severe dengue are further stratified into 3 tier, and it's severe plasma leakage, severe bleeding, and severe organ impairment. As I said just now, the classification bodes well with clinical management. For example, if a person has severe dengue, the person must be admitted, and ideally they will be admitted to critical care. Failing that, if beds in critical care are not available, they should be destined and disposed to specialized dengue wards. Dengue fever with warning signs, which are the intermediate criteria, non-severe type of case, would need admission for further management, for further monitoring. And finally, the majority of patients who have 0 complications or very minimal complications, they will only require outpatient monitoring and treatment. So if a person has severe dengue, your treatment is much more intensive. Start off, for example, in severe plasma leakage. One subset of severe plasma leakage are patients with decompensated shock, D-shock here, what I've written. They require 20 mL per kilo of intravenous fluid, and that has to be run within 15 to 30 minutes. And hopefully one cycle will have rescued the patient from shock and put them out of shock towards normotensive levels. The second less severe group in severe dengue with severe plasma leakage will be those with compensated shock. They would require also quite an intensive fluid regime. They need up to 10 mL per kilo per hour be given within the first hour of recognition of compensated shock. And finally, in this subset of severe dengue, you can have either a patient who did not respond to decompensated or compensated rescue boluses. they might be in the same situation with patients who bleed, so-called bleeders. And bleeders and people who fail to respond to rescue boluses will require packed cells transfusion, and some require repeated packed cells transfusion. So in other words, these are patients who needs critical care management and monitoring. Now, the patients who get admitted to the hospital without entering the critical care units are patients with dengue with warning signs alone. Now, this is a huge spectrum of patients, from patients who have only a single warning sign to multiple warning signs, but without any features of severe dengue. They require, again, because of the spectrum of the severity, they require a spectrum of, you've got a spectrum of choice to give them, from a maintenance regime between 1.2 to 1.5 mils per kilo per hour to a combo regime where you can combine rescue boluses, and the rescue boluses are less intense. It's between 2 to 7 mils per kilo per hour. Now, and finally, you have dengue fever patients who only have dengue fever, no features of severe dengue, no presence of warning signs, and they will require only outpatient monitoring. They will only require oral fluids 2 to 3 liters per day. So I've kept it simple so that it's easier for researchers to understand the degree of severity and the degree of management, the aspect of management involved in this stratification. There is, I like to highlight that there existed in the past, before 2009, WHO 1997, the previous criteria to classify dengue. And if you read up dengue literature, you will find even up to 2021, people are still, or researchers are still performing studies, also looking at and utilizing the WHO 1997 criteria. 1997 criteria divides the dengue classification into two: dengue fever alone and dengue hemorrhagic with or without dengue shock syndrome. So there is a challenge, there is a dilemma. Which one do you use? So a group from WHO called the Dengue study group decided that let's look at how the two classification between 1997 and 2009 bodes to the final clinical management of patients. So they divide clinical management into the standard management, where you don't require any IV fluids. So as I've mentioned back for 2009 criteria, these are patients who are treated as outpatient. They only require oral fluids. Then you've got category 2 patients who only need some rehydration via intravenous fluids, some maintenance, perhaps some platelets or fresh frozen plasma, and just a simple oxygen therapy. But then you've got category 3, major intervention, and this is what you can classify as patients who are in severe dengue, which require shock resuscitation, would require packed cells transfusion, inotropic support, more intense respiratory support in terms of CPAP, BiPAP, or even intubation. So what did they find? So they find for the 1997 criteria, as I've said, that it's divided into dengue fever and dengue hemorrhagic fever with or without shock. There is a lot of discrepancy. The dengue hemorrhagic fever classification covers not just major but also intermediate type of intervention, and that's difficult when you've got to be specific in terms of your treatment, in terms of your monitoring. So they found that the sensitivity is poor, well, sort of quite reasonable at 76%, but the specificity is quite poor. It's just a little bit better than chance. The specificity was 54%. So That's 1997. How about 2009? The Dengue study group found that the 2009 criteria is very congruent with clinical management of patients. So the sensitivity was 96%, the specificity was 97%. And as you can see from the second set of column, for 2009, severe dengue is very congruent, parallel with the amount of the major patients who receive major intervention, and the rest who are non-severe also is congruent with the intermediate strategy of management or intervention, and also the standard management. So the reason also why I highlight this is that with the next slides that I'm going to show you, I'm going to discuss about severity and also mortality outcome of dengue. We have to bear in mind that when people use dengue hemorrhagic, when authors use dengue hemorrhagic fever classification of 1997, the severity is much wider. There's a large chunk of patients who are really non-severe, who did not require major intervention, as opposed to if researchers or authors were to use WHO 2009 criteria, it fits well with the clinical management of patients and finally outcome. So let me touch first on how the comorbidities affect severity of illness in the course of dengue illness. Let's take the latest evidence from Lancet, which was published in 2021. So they had a series. They performed a systematic review and final meta-analysis. The participants that they selected from the studies, they selected studies which captured patients who were in the febrile phase or within the first 4 days of dengue illness, and they measured their outcome measure was who would develop severe disease, and they look at both the WHO 1997 classification and the 2009 classification. They started off with more than 6,000 records, and they look at finally they filtered it down to 120 studies. And what did they find? And I like to highlight only adults, because in Malaysia, 95 to 99% of cases currently are only in adults patients. 99% of mortality will be in adults. It wasn't like back in 1970s where a large proportion of dengue cases were pediatric in nature, and the mortality were pediatric. Things have changed. So biggest contributor to disease modification in terms of who would develop severe disease: firstly, diabetes with an odds ratio of more than 4. Secondly, renal disease, people with CKD and end-stage renal disease, again, odds ratio more than 4 times compared to those without renal disease or diabetes. And then comes cardiovascular disease, people with ischemic heart disease, coronary artery disease, heart failure, and finally, people with secondary infection. Secondary infection modifies the outcome of who will get or who will carry on to develop severe disease. A large study from Mexico, quite a recent one as well, looked at 24,000 patients with dengue fever in the community, and they look at who would end up being hospitalized. And what did they find? Again, diabetes is a big factor there, but also hypertension, chronic kidney disease, people who are immunosuppressed, for example, patients who are being given with immunosuppressant drugs, people with HIV, patients with cirrhosis, and patients who are pregnant. Now, I like to sidetrack a bit, just to highlight, as I've mentioned earlier, that I like the audience to think about the quality of studies. If you were to perform dengue studies, you've got to define things clearly. The weakness of this Mexican study was they did not specify explicitly how did they achieve diagnosis confirmation. For example, a study which confirms dengue by way of PCR and NS1 is much a better study compared to studies that includes a method of confirmation of dengue diagnosis with IgM, because IgM has a lot of cross-reactivity. And secondly, in this paper, what I would criticize is the outcome measure. They mentioned that the outcome measure is hospitalization, but unfortunately, the authors failed to specify explicitly what were the indications of hospitalization. For example, in Malaysia, we are a lot more specific. People who get hospitalized are patients with severe dengue and patients with dengue fever with warning signs. Now, that is much more objective. That is much more clearer in terms of defining. So in this paper, they did not specify what was the parameters to have patients ending up being hospitalized. Another paper that came out from Singapore, and they look at 1,000 patients who were hospitalized, but in this study, they move a little bit higher level in terms of who among the hospitalized patients developed severe organ impairment according to WHO 2009 criteria. As I've mentioned, severe dengue based on WHO 2009 criteria are divided into 3: severe plasma leakage, severe bleeding, and severe organ impairment. So they look at who end up developing severe organ impairment. And what did they find? They find that if anyone has any pre-existing comorbidity, there's a disease modifier. If they have 2 or more existing comorbidities, the adjusted odds ratio increases almost to twice. If you have, again, diabetes, if you have asthma, if you have cardiac disorders, these are disease modifiers. But what I also like to highlight, look at the 95% confidence interval, because, for example, the 95% confidence interval for asthma is just above significance at 1.04. So I think if you go by grade guidelines, anything that is within 1 to 1.115 is still not as strong evidence compared to if the odds ratio were to be above 1.15. But that is still a subjective decision. Again, my criticism in this paper is that the authors did not explicitly specify what was the indication for hospitalization, how was diagnosis confirmed, what sort of patients at baseline were they, how bad were they when they were first admitted. And one thing in mind that we have got to remember, their outcome was only solely specific to severe organ involvement and did not encompass the full spectrum of full severe dengue according to WHO 2009 criteria. What about mortality? So there are some papers that look at mortality. Again, the Mexican paper that I've mentioned, they also look at mortality as an outcome, death. So they find, again, diabetes, hypertension, chronic kidney disease, and pregnancy are important modifiers of outcome. A paper, and this is a huge study from Brazil, and their participants are patients who are 9 to 45 years old. They took from the years 2008 to 2015, and they had over 3,000 hospitalized dengue cases. And what did they find? In the first column are the patients with dengue fever, and the second column are patients with dengue hemorrhage fever. So as you can see, they are still using 1997 method of classification. So I like to highlight that they are using as a statistical measure case fatality rate, CFR, and they use here I've highlighted people without comorbids. So people who are without comorbids, dengue fever, the case fatality is 0.14. So they take that as the reference value. So they would compare to other subgroups of patients. So here the reference value becomes a relative mortality rate of being 1. So when you compare with dengue hemorrhagic fever, you've got a case fatality rate of 2.73. And that is 19 times higher as compared to patients who without any comorbids who have dengue fever. And next, you have, if you factor in the presence of any comorbidity as compared to patients without comorbidity in dengue fever, the risk is 13 times higher. There's 30 times more patients who died when you have a comorbid. When you have dengue hemorrhagic fever, the figure becomes 100 times larger. If you go to specific comorbids, diabetes. So if you are dengue fever with diabetes, you are tough. The numbers of case fatality increases by 12. But if you are diabetic and you end up with dengue hemorrhagic fever, the case fatality rate becomes 170-fold higher. If you have some sort of concomitant infection, whether acute or chronic, your risk, if you have dengue fever, is, I'm sorry, let me rephrase, not risk, but the case fatality rate becomes 70 times higher. In dengue hemorrhagic fever, it becomes 100 times higher. If you have pulmonary disorders, it's 13 times higher for if you have dengue fever, but it becomes again more than 100 times higher if you have dengue hemorrhagic fever. And similarly, in patients who have renal disease, chronic kidney disease, or end-stage renal failure. And finally, I like to highlight this paper, which covered. It was a systematic literature review which covered all the important studies beyond the last 5 years. What I've discussed previously are papers that has been published within the last 5 years, and this is the literature review that covered the literature beyond the last 5 years. So if we look at studies that use an outcome of severity in terms of severe disease, and here these are the papers that look at dengue hemorrhagic fever, again utilizing 1997 WHO criteria, same disease, hypertension, diabetes, with important odds ratio, although some are a bit iffy at 1.02 if you look at the 95% confidence interval, but nonetheless they are significant. In terms of mortality and death, these are the papers and these are the evidence. It's much more obvious. The odds ratio covers between 10 to up to 44. And the risk factors are again the same: diabetes, hypertension, cardiac disorders, renal disorders. There were studies which did not calculate or present odds ratio, but just look at p-values in terms of statistical significance. These are studies which actually examine severe dengue and how they actually cohorted. They look at who developed severe dengue, specifically acute respiratory failure. And these are Taiwan studies, and risk factors that they found were people with previous stroke, CKD, patients with hypertension, rheumatological disease. And what about mortality? Again, one of the study that I've shown in the previous slide, one of it also looked at examined mortality among dengue hemorrhagic fever, but in a specific population in the elderly, and they found in the elderly disease modifiers are still the same: hypertension, patients with previous strokes, COPD, CKD, and also corticosteroid use. Now, I like to show this. I think it's important to highlight that there are studies that found that there were no significant risk factors to say which comorbid would lead to a different outcome in terms of severity or mortality. So two studies, one study look at death, another study from Pakistan look at the DHF, another study from Thailand look at whether patients who would develop clinically significant bleed, they did not find any important risk factors, any statistically significant risk factors. Before I go further, I like to highlight, I think in my clinical experience, a lot of clinicians and researchers have got things confused. I think it's important to remember that comorbids are different from a severe form of dengue. In dengue, people, there are patients who develop acute kidney injury or acute renal failure, and this is a complication of the dengue illness itself rather than an existing comorbid illness like CKD or institutional failure. Now, what I've presented so far is how a factor, a comorbid, would modify the outcome of the illness. What I also like to highlight here is how in a certain subset of patients, for example, in Fonseca 2021, the Mexican study of 24,000 patients with dengue fever, 23.4% hospitalized. So if we were to do a study, how many of these hospitalized patients were actually has a specific comorbid, for example, 5.3 for diabetes, 5.3% of these hospitalized patients had diabetes. I think this is important because it's important to appreciate, because when we do a study, we need to calculate the sample size and we need to figure out how long would the study take. So as you can see here, if you were to study, just take the hospitalized cohort and see who dies or who develop even further severe illness, you will appreciate that from all the hospitalized dengue patients, only 5.3% had diabetes. So this will impact both your sample size calculation and also your length of study, how many patients you will be able to recruit in how much time frame. In PANG 2017, they've already got their hospitalized patients, and they were looking at severe organ impairment. And among the hospitalized patients, they only had 16.7% who developed severe organ impairment. Within that 16.7% of severe organ impairment, only 13.2% has 13.2% has diabetes. So again, this will impact your study size and your study duration, and hence when you can publish your results. Study into the death again. If you are looking at mortality, case fatality rate in Fonseca, in the Mexican study, is only 0.58%. Diabetics were only 15%. In Brazil, those who are dengue hemorrhagic fever, the case fatality rate is much higher, it's at 3%. But when you look at patients with dengue fever, it's 0.16%. And this is why Brazil, I think they use a registry rather than a cohort study. And one more thing I think that we need to appreciate is factors contributing to outcome and events. What makes research in dengue difficult is what actually are the true contribution to outcome or event. Is it solely the pathophysiological processes, or is it also the clinical processes that occurs? we've got to adjust or control for clinical processes. For example, late presentation, and an element of low mortality rate. Hence, you've got to have a bigger cohort and a longer time in terms of recruiting patients. Ministry of Health of Malaysia.
Sorry, apologies, Dr. Saiful, you have another 5 minutes to go.
Sure. So the Ministry of Health conducts mortality reviews, and these were the some examples of how clinical processes impacted the outcome of patients, the events being mortality. So it varies between how there was error in clinical assessment, inadequate fluid management to up to unavailability of ICU beds, as simple as that. So as you can see, if one were to research what is the pathophysiology of dengue, it can be confounded by all these factors. Now, I like to show here the last thing that I like to highlight in my talk today is endothelial glycocalyx. On the left-hand side is a cross-sectional cut of a blood vessel, an electron microscope of it, and the grass-like structure is actually the endothelial glycocalyx. Zooming in 10 times higher on the right-hand side is what the endothelial glycocalyx looks like. These are proteoglycans, glycosaminoglycan structures. And I believe this holds a big role in the pathophysiology of plasma leakage, and plasma leakage is central in dengue fever clinical manifestation. Disruption of endothelial glycocalyx, I believe, plays a big role, and it occurs in dengue, sepsis, diabetes, and CKD. There are papers which measured syndecan-1 levels, a biomarker of endothelial glycocalyx. In healthy controls, in nanograms per mil, one study found it to be about in the region of 26. If you have CKD, it's 3 times higher. If you have septic shock, it's almost 10 times higher. If you are diabetic type 1 with microalbuminuria, from nanograms per mil, it becomes 100 micrograms per mil. If you have severe dengue with severe plasma leakage, and this was published by the Oxford Vietnam group, Bridget Wills and Sophie Yacoub, the levels becomes 100 times higher. So my take-home messages is simple. Firstly, diabetes, CKD, concomitant infection, lung disease, and hypertension are important disease cause modifiers. Endothelial glycocalyx could be the underlying final common pathway in dengue outcome pathophysiology. As you can see, it occurs in many diseases. So it could be the final common pathway in why people have plasma leakage. And finally, I think when we conduct research, we need to address quality gaps here in previous studies, but also bear in mind researching dengue, given the traps of clinical processes, making researching dengue tricky. Thank you very much, Dr. Fadzilah.
Thank you very much to Dr. Saiful. So we have to move on to the second talk. Meanwhile, if any of the audience have questions or clarifications, including comments, you can post it up to the our chat box. So thank you, Dr. Saiful. You always can check the chat box. And if anyone who would like to ask questions virtually live here, we can wait for Q&A session after the second talk. So without further delay, we will pass the mic to Dr. Jeyanthi.
Yeah, thank you, Dr. Fadzilah. So I will start sharing my screen. Okay, able to see my slide? Right. Okay, good morning, dear colleagues and audiences who are here today to listen to the Dengue Symposium talk. And my topic today will be on dengue detection, advances and challenges. Right, so I will bring you through these contents today in my talk, which will cover a brief introduction on dengue virus and its properties. And we will also look into the past and present situation of dengue in Malaysia. And of course, the highlight of my presentation today is on the advances in diagnostic tools. So from conventional to point of care, what we have now, and brief also a brief overview on the challenges and future direction. Right. So here we have a brief introduction on the dengue genome structure. The structure of dengue virus was first discovered in 2002 and elaborated via cryo-electron microscopy technique. So they found 11,000 or 11 kb plus sense RNA genome and codes for 3 structural proteins, namely the envelope, membrane, and capsid, and additionally 7 non-structural proteins, which are the NS1, NS2A, 2B, 3, 4A, 4B, and NS5. And they are coded in this direction. From the 5' to 3', we have the C, the core, the pre-membrane and membrane, envelope, and all the non-structural proteins. So of these 10 proteins, the E protein is a frequent target to study the variants. Why? Because it has high heterogeneity, meaning that the nucleotide sequence of the E protein is highly differs from serotype to serotype. So it is a good target to study variants in dengue virus. On the other hand, the NS2B and NS3 proteases from all dengue serotypes share structure and function similarity. So these two are considered as the most powerful therapeutic target for development of effective drugs. Well, as some of you might have known, upon infection, NS1 protein is secreted in the host, and that can be detected using a rapid antigen test kit. So it's a good biomarker. Until now, to date, we are still relying on this NS1 protein to indicate acute dengue infection. Right. So a unique feature of dengue infection is the serotype shift phenomenon. A serotype shift is actually a phenomenon where one predominant serotype of dengue is being replaced by another serotype at any given time, any years, or any season. So the actual cause of this phenomenon is unknown. Why it's happening, it's quite not clear yet. However, it's interesting to see a pattern, although it's not consistent. For instance, if you look at the statistics shown here, the graph which I retrieved from this publication by Mohd 2015, we can see to a great extent that the serotype shift is being displayed here from the year 1990 until 2014. Initially, there was a predominance of dengue virus 2, and then dengue 2 was then replaced by dengue 3, and then dengue 1, and so on and so forth. But dengue 4, usually it remains at the background level. It's not so commonly found in Malaysia. So yeah, that's about the serotype shift. Right. So what is it like in dengue distribution worldwide in the recent 3 years? So from 2019 to 2020, there was a massive global outbreak of dengue, where cases spiked up to few hundred thousands annually in most of the endemic region of the world. However, in 2021, there seemed to be a decline in the number of cases, as you can view here in the graph, in the map shown here in 2021. Right. How is it like in Malaysia? What's the current situation? So we are moving into 120 years of endemic journey of dengue in Malaysia. And so here's a bit of a timeline of dengue outbreaks in Malaysia. Dengue was first discovered in 1902 in Penang. It was discovered in 1901, but it was only documented in 1902. And then after that, we had the first severe dengue outbreak in the country, which occurred in 1962, also in Penang. And after that, only in 1973, MOH made dengue as a notifiable disease due to following the outbreak in Jinjiang, which actually killed about 54 people, and dengue 3 was incriminated as the major serotype during that outbreak. Right. And then in 1997, we also had major outbreaks. The causative serotype was dengue 1, dengue 2. After that, we had many subsequent outbreaks, including in 2004, 2005, and then 2007, 2008, and 2015 to 17. All these are caused by, we saw a predominance of dengue serotype 1. Okay, so this statistic shows the number of dengue cases from 2000 to 2021, which I obtained from the iDengue website. So for those who are not, who have not browsed this website, so iDengue provides dengue statistics in Malaysia, including the hotspots, information on the hotspots, and so on. So here, as we can see, Malaysia had an unprecedented dengue outbreak from 2014 to 2016, where cases hiked as much up to 120,000 cases per year. And after that, we saw a slight reduction, and it picked up again in 2019, and again there was a drop in 2020 till 2021. So here also to outline the drastic decline in the number of cases in 2020, where the number of dengue deaths reduces as much as 20.3%. And one of the causes that could have contributed to this, why dengue has reduced so much in 2020, is of course because we were having another issue, which is the COVID-19 pandemic. So this paper captured some interesting findings where they noticed that during the implementation of MCO, which is supposed to break the COVID-19 infection chain, but it also had some positive effect on the onset of dengue cases. Where the highest reduction of new dengue cases were reported in the central peninsular region, followed by the northern peninsula and eastern coastal region. However, this situation did not remain long, where new cases of dengue started to increase during the MCO phase 3, obviously because during the MCO phase 1, a lot of restrictions were imposed where people tend to stay indoor rather than outdoors, so perhaps the cases have reduced. But during the MCO period, phase 3, a lot of leniency has been given, so people were still moving in and out, so that could have contributed to the increase in the cases again. Okay, so moving on to the laboratory diagnosis of dengue. So this is an overview of the current available laboratory diagnosis. We have virus isolation, which is considered as a gold standard. And here I have shown the uninfected and infected cell lines. There is a wide range of cell lines that can be used to isolate the virus. So this is an uninfected cell, and then this is the infected cell. So the virus isolation, the success of virus isolation is judged firstly based on the CPE, which is the cytopathic effect. Cytopathic effect is actually the morphological changes that is induced due to the viral infection or effect of the virus to the host. And then, so since this is very subjective, and it's usually explained or interpreted in the manner of scores, you know, I can say that this cell, the CPE is 1+, 2+, 3+, and so on. So it's very subjective. Eventually, we have to proceed to other assays to quantify the degree of the virus growth in the cell. For instance, we can use a plug assay, a focus forming assay as shown here, to check the viability of the propagated virus, or we can also proceed to immunofluorescent assay to capture the antigen. In addition to that, we also have antigen detection assays. So basically, it captures the antigen of the dengue. Mainly, it's the NS1. So now, with advances in technology, we have combo kits, okay, that combines the NS1 as well as the IgM-Ig. So it's the antigen plus the antibody detection. So it's a very good POCT that is useful in the hospital settings, especially. Okay, then we have PCR. So real-time RT-PCR is a very useful technique that can be used to detect dengue and all 4 serotypes of the dengue. it has faster TAT than the virus isolation. So in IMR, we use this technique, a real-time RT-PCR for detection and serotyping of dengue samples that are being sent to us. So the interpretation here is qualitative. It's either positive or negative, detected, not detected, with the information of the serotype, whether it's dengue 1, dengue 2, dengue 3, or dengue 4. And then we also have laboratory diagnosis based on antibody detection. This is particularly useful in differentiating the recent and past infection. Recent infection is characterized by a high titer of IgM, whereas past infection is or secondary infection is characterized by the IgG detection. So what's new in dengue detection technology? So here, first, let's look at the virus isolation. As I have mentioned before, the virus isolation is a gold standard detection. Why? Because of its consistency, its capacity to generate more infectious viruses for future research, and excellent compatibility with a wide range of samples. You can isolate the virus using serum, blood sample, urine, and a lot other range of samples. And also, like for respiratory viruses, you can use the nasal swab and so. So we have a wide range of cell lines as well that is compatible or that can be utilized for dengue virus isolation, including the Vero cell and C63 cells. So basically how it is performed, the cell lines are inoculated with patient samples, example serum, and after which you observe for CPE from day 1 to day 7 usually. So after which the culture supernatant are harvested for subsequent detection or quantification such as plug assay, focus forming assay, or immunofluorescence. But there is a challenge with this technique. It is time consuming, obviously, because you need to wait up till a week to observe the CPE, after which you can only confirm the viability using some other assays. So it's very time consuming, it's laborious, and which is why there is a need to look into new advances in this area. So one of the new advances that I picked from this particular publication is the usage of biosensor technology to capture live viruses. So WASIC 2017 explained the development of a biosensor using single wall carbon nanotubes called the SWNT that mimics the in vitro cell culture system. So basically what the scientists did, they took the single wall carbon nanotube and they functionalized it with heparin as a biorecognition molecule that detects the virus. Now, dengue binds to a wide range of receptors, host receptors, in order for it to be internalized and replicate in the host. So one of the receptors is the heparin sulfate. So here the researchers used heparin, which is a close analog to the heparin sulfate, as a receptor to the 4 serotype. So they attached the heparin or overlaid the heparin to the SWNT, and then they went through a series of chemical treatment, and then this system was able to capture viable viruses via binding signaling. The more virus binds to the heparin overlaid in SWNT, the more signal it releases, and with that, they are able to come out with a quantitative method for detecting viable dengue viruses in patient sample. But what is the problem with this system? It is not able to support growth of virus. Obviously, you can't propagate the virus for future use. You can only detect it, so it stops still there. So yeah, that is a new innovation that could possibly replace the in vitro cell culture assay, but with certain limitations. Right. So what about genomic detection? Current method widely used in genomic detection of dengue is the real-time RT-PCR and serotyping, and the output can be obtained within 4 to 6 hours, including the extraction of the nucleic acid, the amplification process, and the interpretation of the result. Samples, however, need to be taken during the viremic phase. So if it surpasses the viremic phase, you will not be able to detect the dengue virus using this technique. So interpretation is rather qualitative unless a quantitative PCR is requested and performed to quantify the viral copy numbers. But performing quantitative PCR is quite hassle because you have to, if you're doing it manually, you have to build the standard curve and you have to interpret based on the copies number. But having said that, now we have commercially available quantitative PCR kit as well, where they provide the standards in the kit. So it doesn't take that much of time. Well, however, the limitation with real-time RT-PCR is the need for expensive equipment such as real-time PCR thermal cycler. So in resource-limited setting, poor resource countries, where they do not have access to such high sophisticated equipment, this might be a bottleneck. So in order to replace the real-time RT-PCR, a new innovation called isothermal molecular technologies have been recently developed. So what is this isothermal amplification methods? This method do not rely on thermal cycling. Well, in a usual PCR setting, you have several range of temperatures where you need to conduct the PCR. Sorry, can you hear me?
Hello.
Hello?
Yes, can.
Okay, so where in the usual PCR setting, you have several range of temperatures that you need to set in the PCR thermocycler in order for you to get the output. But in the isothermal molecular technologies, you only rely on one constant temperature. So the amplification still takes place, but at a constant temperature. So this significantly simplifies the implementation of nucleic acid-based methods in POC diagnostic device. Right, yeah, so here this RT loop mediated isothermal amplification, which is a new innovation in dengue detection. So it is simple and rapid. Within 30 minutes, we are able to obtain the result at a single constant temperature. So it is well suited for on-field applications, detectable by naked eye due to colorimetric changes. So as simple as that. And with technology advances, now the lamp has been upgraded, where it has been introduced such as digital lamp. They have linked it to a smartphone for you to view the results. Some of them have also incorporated biosensor with lamp, and they have also innovated lateral flow based lamp. But the problem with lamp is false positive and non-specific bindings. So these sometimes regarded as the major disadvantages of the lamp method. Another advantage technology advances in dengue detection is the micro PCR. So quite interesting, where micro PCR allows the usage of a portable PCR system that can be used to detect dengue. There are also a number of NAAT-based platforms in the pipeline that have potentially been used for diagnosis, but today, only the TrueLab real-time micro-PCR system is commercially available. So this system basically uses a chip, okay, that has already incorporated the nucleic acid extraction and the PCR inside this tiny chip, and it has to be inserted into a mini micro-PCR, a portable PCR system that can read or interpret the results, also qualitative, positive or negative. So it's quite interesting. We hope to see this micro PCR being used in many laboratory and also hospital settings in future. Right. So antigen detection. So previously we have enzyme immunoassays, ELISAs, and immunohistochemistries, which are quite effective methods for detecting dengue antigens, particularly from frozen paraffin-embedded tissue sections using labeled molecular monoclonal antibodies. But their usage is limited in regular laboratory testing due to their laborious method. So instead now, we have tests against intact virus particles, and recombinant viral proteins have been established, including commercially accessible NS1 detection, POCT. So this POCT is quite widely used in hospital settings nowadays. Okay, what about the antibody detection? So ELISA remains as the one of the most effective serological diagnostic technique to detect and capture the IgG and IgM particularly. It is quite useful, but the limitation is high cross-reactivity with other arboviruses, because basically the flaviviruses, they share similar structure, antibody structure, IgG, IgM. So cross-reactivity is highly evident. So lateral flow assays are more preferred due to early usage and availability of combo version with NS1 detection. We do have some recent advances in this area, such as, again, the use of biosensors to detect antigen antibody. However, the feasibility of such innovation in the laboratory setting as a POCT is still not evident. So a lot of research or validation still need to be done for these technologies because they have not been commercialized yet. So yeah, moving on to the challenges in dengue detection assays. So what are the challenges that we are seeing? Of course, false positive, false negative. These are the main challenges in dengue detection assay. So a false positive result, basically, it's presented with cross-reactivity. So cross-reactivity with the other circulating flavivirus, as I just mentioned. So particularly the dengue IgM and IgG can give you a false positive result. What about a false negative result? So sometimes NS1 cannot be detected when the level is too low, especially in secondary infection, and if the sample has been collected late. So we need the viremic phase to be maintained in order for you to detect the NS1. IgM can also be not detected. It could cause false negative, especially in secondary infection, whereby the IgM, the titer of the IgG is much higher than IgM. So these are among the pitfalls, challenges in dengue detection assay. Another issue is the prediction of disease severity. Until now, I don't think so we have a reliable assay to help the clinician to predict the disease severity, whether this patient going to end up to have severe dengue, and because the prognosis is not good. So is there any test available to predict the disease progression? I don't think so we have any commercially available test kits to do that. So which means we need to look for new biomarkers in this area. So right now, what is best is combining the NS1 detection with IgM, IgG serology in routine diagnosis of dengue infection can help to improve accuracy of the dengue diagnosis. So, so we have come to the end of the presentation. So here are some take-home messages. The future of testing can be important in improving rapid tests that are affordable and sensitive. But there are challenges, especially variation in serotypes, dengue serotypes, and genomic structure is one of the major concerns that need to be considered in the diagnostic development process. So WHO recommends assured criteria, ASSURED, affordable, sensitive, specific, user-friendly, rapid and robust, equipment-free, and deliverable to end users. So any test kits that are able to fulfill the assured criteria will definitely be useful in diagnosis, in diagnosing dengue. So with that, I end my presentation. Thank you.
Thank you, Dr. Jeyanthi. So I believe, thank you. I believe that what I can say now at this point of time, that both speakers, Dr. Jeyanthi as well as Dr. Saiful, have covered a significant areas of topic in the dengue itself, in the clinical perspective as well as in the laboratory, from the laboratory perspective, with high enthusiasm as well as passion. So with that, I believe that both of them can aid us in answering or clarify our doubts. Yeah. So with that, anyone who would like to pose their questions, or you just may raise your hands and just say it out, your questions. Meanwhile, while waiting for questions to trickle in, there's one question in the chat box for Dr. Saiful from Dr. Ong, I guess. Hi, Dr. Saiful. Is there any place we can get such data in Malaysia? like how many dengue patients develop into severe dengue in Malaysia? Dr. Saiful?
Yeah, okay. So let me share my screen first. Okay. Right. Let me show you this. Yeah. Okay, so there have been three studies which look into this, the prevalence of severe dengue in Malaysia, and good thing, all three papers look at the WHO 2009 criteria classification method. So the first paper look at 6%. That was our paper, and in fact, I wrote it with Dr. Julina from UiTM Hospital Sungai Buloh. She's an emergency physician, so we wrote it together. So we found in that study it was 6% prevalence. Other studies from Ahmad and Zakaria were about 5% as well, so not too far off. So that's the prevalence of severe dengue in Malaysia. In HKL, what we've done is we've collected, I maintain a severe dengue registry. So all the cases who were diagnosed by the end of the discharge, at some point of time during the stay, they've been diagnosed severe dengue. We kept it in a registry, and it has been suggested in our, as I've mentioned in my talk, the quarterly mortality review at Ministry of Health. We've recommended that all centers keep a dengue registry, but it is not a formal registry. So it's up to centers who want to keep it. So I think for HKL, yes, there is such data, the dengue cohort, and we can always compare in terms of how many dengue patients were admitted for that year. So then we have the prevalence of dengue amongst hospitalized patients in HKL. I can't say the same for other centers, but for Ministry of Health hospitals, they should be keeping a local registry.
Okay, I hope it does address the Dr. Ong questions there. And before we move on to Dr. Jeyanthi, there's quite a number of questions for Dr. Jeyanthi. Anyway, to Saiful, I would like to ask if everyone can remember one of the slides that you showed that one of the AOR of the cardiac disorder give a bit, compared to the rest of other comorbidities, is a bit high compared to the rest of other comorbidities, which is the cardiac disorder as well as the diabetes mellitus. So if you see there, for cardiac disorder, they didn't really separate between the what do we call, is there any contributing factors in terms of hyperlipidemia, in terms of the whether they have high triglyceride, that kind of things, and they whether they really lump it together with a related cardiac related disorder. So that one, if you can enlighten us a bit further on that particular issue. And the other one, is it due to the dengue myocarditis, which may contribute to the mortality or the significant number or percentage of the AOR itself?
Okay. Yeah. So I think in this paper, the adjusted odds ratio was specifically at cardiac disorders, and they've adjusted by age group, gender, and including the specific diseases, diabetes, hypertension, hyperlipidemia is taken as a single separate factor. This cardiac disorder, which encompasses coronary artery disease and heart failure. And then you have asthma. So I think rest assured for this study, hyperlipidemia has been taken out and exists as a separate factor. But your second part was, what was it again?
Is it due to the in the
Yeah,
cardiac disorder? Is it due to the dengue myocarditis itself?
Yeah, so they are looking at pre-existing conditions, pre-existing comorbid, myocarditis, cardiac myocarditis in dengue is taken as part of a severe dengue, the complication of the illness itself, and not as a comorbidity in the study.
I see. Okay, thank you very much for the clarification. So now, I guess, Dr. Jeyanthi, the first questions for you. What is the status of sylvatic dengue in Malaysia currently?
Okay,
Yeah.
so sylvatic dengue, for those who do not know, it's actually the dengue virus circulating in the Aedes. It's not in the human. So Aedes mosquitoes, or it's found in the jungle area. So the current status, as far as I glanced through the NCBI website, where we have the deposition of the sylvatic dengue sequences, we still do get sylvatic dengue, especially dengue 4. I noticed there's a recent publication in 2019 that described a high proportion of sylvatic dengue 4 circulating in Malaysia, particularly in the urban area. So that would be the status of sylvatic dengue still circulating.
Okay. Number 2 questions from Muhammad Zuhaimi, HTJ. What is doctor opinion if the lab diagnostic only do the test either IgG or IgM or NS1 only?
Okay, so, well, I think, in my opinion, it is better if we combine the NS1 plus IgG and IgM for better interpretation, because you can easily miss one or two, or it can actually, if let's say you are, sometimes it's negative, totally negative, IgM negative or Ig negative, let's say you are not using the NS1. But in fact, the patient, the real condition of the patient is the patient is actually in the viremic phase, but you do not have access to NS1 test. So your IgG and IgM will show negative, and you will misinterpret it as a negative result. The patient is not being infected. So that will cause a false negative, and you will get the patient discharged. So I think it is always better, even the WHO and CDC recommends the combo kit, the usage of IgM, IgG plus NS1 for better interpretation.
Okay, more questions for you, Dr. Jeyanthi. Hello, the various detection methods of dengue virus, which would have the best specificity and sensitivity? What is the recommended specificity and sensitivity level in the virology lab?
Okay, so when you talk about specificity and sensitivity, various techniques have different level of specificity and sensitivity. But for dengue detection, the best would be the real-time RT-PCR that has, I can say, the best specificity, because it has to be 100% specific to all the serotypes, and sensitivity can range up to 95% to 100%. Of course, there is no one test that is like perfect 100% sensitive and specific. So we have a range, 95% to 100% is acceptable. But still, we do have other assays like the NS1, IgM, IgG, which has lower sensitivity. We have a study in the Southeast Asia performed in Vietnam. They compared the sensitivity and specificity of these tests, and they found that the NS1 and the IgM, IgG, which are widely used, has actually lower sensitivity, about 70% to 80%. So it performed very differently in different regions of the country. So I would say the best is to use the real-time RT-PCR in combination with other tests.
Okay. All right. And then some more. Hi, Dr. Tan here from HPP. Are there any latest updates regarding the dengue vaccine?
Well, I think we had the dengue vaccine previously by Sanofi Pasteur, but then there was some issue with that, and then of course some of the countries have actually approved the licensing for the dengue vaccine, but there was some issues, especially in Philippines. And then we have another one, I think currently ongoing phase 3 or phase 4 clinical trial, which is the Takeda vaccine. It's quite promising, and they are right now doing some clinical trials in various countries. So it's quite promising, the Takeda dengue vaccine.
Dr. Saiful, if you may add something on dengue vaccine?
Yeah.
Yeah.
I think Dengue vaccine did want to try to come in to Malaysia, but there was a big meeting at NIH and also in Ministry of Health. We decided to reject because basically what the paper that was published in if I'm not mistaken, New England Journal of Medicine, basically implied that for if the patients were to be exposed post vaccination, there were higher proportion of patients who developed or went on to develop severe dengue. So that defeats the purpose of having a vaccine. The reason why you have a vaccine, you want to avoid mortality, you want to avoid a worse outcome, reduce the severity of an illness. So that's why we rejected, and I think Philippines decided that yes, it did help at the end of the day. So that's why dengue vaccine did not proliferate in terms of its use. Takeda has tried to come in. I attended one pitch from them. They wanted to organize some a study in terms of how the community were ready to accept a dengue vaccine, how clinicians would be ready. So sort of a perception and a knowledge, attitude and perception kind of study by Takeda. So again, this year suggests that there's a lot of issues still if even the pharma company are trying to gauge perception issues in vaccination.
Yeah. Thank you, Dr. Saiful. Back to you, Dr. Jeyanthi. What is the trend of detection of dengue in Malaysia? Antigen or antibody testing? What is the marker for detection and what method are we using in Malaysia? I guess some of your slide has actually
yes. So
the answer.
I mean, correct me if I'm wrong, Dr. Saiful, because he's in the hospital setting, so he might know well. But actually, so in the hospital, upon admission, they are doing the combo NS1 IgM IgG testing, and then after that, clinicians would evaluate most the patient based on symptoms, and so that is the hospital part. Whereas for us in IMR, these samples, regardless whether it's IgM positive or Ig positive, but usually the NS1 positive samples are sent to us for serotyping as well as detection. So we will perform a real-time RT-PCR in IMR as well as in MKAK also, if I'm not mistaken. So the real-time RT-PCR will detect the virus and will let us know what serotype is that. And after that, we will feed back to the hospital on what serotype. So the serotyping is a part of the national surveillance, dengue surveillance, that is being done constantly. So this is the algorithm. I think I also answered the other question. Yeah, currently this is how we do the laboratory diagnosis. As for other tests like viral isolation is not compulsory. You can, if you have access to BSL2, you can proceed for virus isolation, but usually virus isolation and other like ELISA is being done on research basis mostly.
Okay. I guess
can I add on to that, Dr. Fadzilah?
Sure.
Okay. The way to go, what's been recommended by the clinical practice guideline, and the clinical practice guideline does lay out how dengue should be diagnosed. I think there's a clear method. It's simple. It's clinical manifestation. So in Malaysia, because dengue is endemic, anyone with fever, the first differential diagnosis that should be considered is dengue. And the next step is simply to do your dengue combo test kit along with your full blood count. Full blood count is always second, because in the first 2 days you might still have normal total white, normal platelet. Thrombocytopenia and leukopenia comes in after 48 hours. Studies from Vietnam has shown that clearly in terms of the kinetics of the blood cells in dengue patients in 4 serotypes, in both dengue fever and dengue hemorrhagic subtypes. So in Malaysia, we do combo tests. The reason for combo test, because the first 3 to 5 days, you really need your NS1. Unfortunately, NS1 would disappear after even as soon as day 3. And that's when you might have to fall back on your antibodies. However, antibodies might only start to raise after day 5. So there's a window period where things could be negative. You've got to go on just clinical symptoms, and you repeat your combo test again later, and hopefully the antibodies would show up if there is. I saw one question asking, what if you do a PCR and PCR is negative, but the features are still, the NS1 was positive. Okay, timing of samples is very important. For example, if you send the NS1 early, of course, you're going to detect the NS1 being positive. I think it is a very high sensitivity if you do it even the first 2 days. And it falls off to by day 5, day 6 to 50% in terms of this detection rate. So, you need your NS1 early. Later on, you might have a window period, and that's when things are negative. So NS1 might be detected, but if you send your second sample, your PCR sample later on, you might not detect anything. So timing is important. If you have a lot of leftover from your NS1 sample, you may be able to use that.
Thank you for highlighting the importance, the importance of the specimen collection. What day that we have to send for PCR, what day that we have to send for NS1 antigen, as well as for the antibody. Yeah. So back to Dr. Jeyanthi. As of now, we have flavivirus surveillance and DVSS. A patient dengue antibody detection result were all negative. So we proceed with flavi PCR and dengue PCR. However, the results show were flavivirus not detected, but dengue detected. May I know what's the probability of this to happen? What's Dr. opinion on this case? Thank you. Part of it, Saiful and Dr. Jeyanthi have answered just now, but maybe you may have to just focus on, may I know what's the probability of this to happen? Yeah.
Okay, let me digest that.
Yeah.
Okay, so you proceed with flavivirus PCR and dengue PCR. May I know, is it a conventional PCR or real-time RT-PCR? We need to know the nature of the PCR test. So basically, if it's flavivirus PCR, it's detecting the family. Maybe it's just a false positive, because dengue is definitely a flavivirus. So
correct.
both flavi and dengue has to be detected. But if there is a misdetection, flavi is not showing up, probably you need to look into the primers and probe that you're using for the detection. So maybe it's not working anymore, or maybe there is some defect, degradation of the probe and things like that. So usually in this case, if the result is quite quite inconclusive, we will look back at the reagents. So if let's say we detect some faultiness in the reagent, we will reorder, or we will look for other alternatives, primers and probes that have been published perhaps and validated. So you need to look back, blast your primers and see whether it's still picking up flavivirus, whether maybe sometimes these primers are designed at the region where the mutation has occurred, so it might not pick. So you need to look into the primers and probe sequences.
Correct. Agree, Dr. Jeyanthi. All right, and then the other questions, I guess both Dr. Jeyanthi or Saiful can comment about it. Is there any national algorithm for dengue diagnosis? Yes, I can answer that. Of course, we do have in CPG guideline. It's very clear over there. And what is your opinion that some people said that dengue test result is not as an urgent test because the clinician can do treatment based on clinical symptoms and also other tests?
Okay, I think that's not accurate. I think, like I said, if anyone with fever walks into a general practitioner's office, clinics, the first thing that you have to consider is dengue. If the patient does have fever, then please proceed to performing a dengue combo test kit. If you're confident that the patient is within first 48 hours, you can do with just a single NS1 test, and hopefully that will capture it. So I think it's crucial. Full blood count is always second. The main thing is to do the antigen or the combo test kit.
Dr. Jeyanthi, would you like to comment? Add more to that? It's okay? It's okay, right?
Yeah, it's okay.
Yeah. So more question for you, Dr. Jeyanthi. Does IMR have any study on cross-reaction between dengue serology with COVID infection causing false positive dengue rapid test?
Well, I'm not really sure about that as much as I'm concerned. Perhaps there are some researchers already looking into it. Yeah, but so far there is no publication related to this. So I'm not so sure.
Yeah. All right. So back to Dr. Safuan. What do you mean? Safuan. Yeah, Safuan can,
Yeah.
Saiful also can. So what do you mean by combo fluids?
Okay, combo fluid means a combination of fluids regime. So, for example, you might design that you want to give an initial higher regime, more intensive regime, like 7 mils per kilo per hour for the first hour, and then you tail off to a lower regime of 5 mils per kilo per hour in the second hour, and finally in the third hour you go down to, say, for example, 3 mils per kilo per hour. All this in between decisions, all these are made in looking at the response of the patients to each regime, each part of the combination. So
Yeah.
you can design and you can stop in between. Let's say if you decide to give 7 and 5, and before going to 3 mils per kilo, the patient is already recovered, and you decide to go into a maintenance, that's fine. But combination means it's a combination of a regime.
Yeah. And then still on you, Dr. Saiful, postural measurement to track postural hypotension still relevant in Malaysian hospitals?
It's very relevant. If the patient is tachycardic, we start screening every 4 hours. That's the standard frequency of nursing monitoring, looking at the patient's hemodynamics. So any indication that the patient is could likely develop shock, we will start doing postural blood pressure measurement every 4 hours. That is quite standard.
Yeah. All right. So I guess this is the last questions for Dr. Saiful and for the whole dengue symposium. As Dr. Jeyanthi is not really feeling well, she need to go soon because she had a bad cough. But last questions to Dr. Saiful. Is there any clinical importance of knowing endothelial glycocalyx in final common pathway in dengue outcome?
Okay, like I've suggested in my talk, I think these are putative mechanisms to plasma leakage in dengue. Could it be very relevant in future if we are able to come up with biomarkers that could detect development of disruption of endothelial glycocalyx? Definitely yes, because to know a patient that would develop severe dengue earlier is always a good thing. It's what we clinicians would want to have in future. And again, could it be a point where an intervention could be explored? People have explored in terms of how fresh frozen plasma would help to repairing the endothelial glycocalyx in mouse models. We suggested yes, it could play an important role to repairing glycocalyx. So yes, it could represent an avenue where intervention could be found or created.
Okay. So I guess I'm so sorry just now. Just one last burning questions. I guess you may have to answer that. From Dr. Amar Tamimi. The first question I will email to Dr. Jeyanthi. The second question, what are the latest control measures implemented in Malaysia?
Okay, control measures. I would say that it's vector control measures. It's integrated vector control measures, larviciding, fogging, mist blowing, community-based intervention in terms of education. So
Okay.
it's taken as integrated approach. So they do not just one aspect but multiple.
Yeah. Okay. With that, I would like to say thank you very much from the bottom of our heart to both speakers, to all the participants, and the questions of our Q&A questions session is very active, I may say that. And I have to apologize for the any questions that we are not able to address it. We will email to you the answer from the both speakers. Yeah. So with that, I thank you very much for all the participation, and to both speakers, Dr. Saiful, Safuan, Muhammad Sani, together with Dr. Jeyanthi. And we really hope that you will join us again in next coming webinar next year. With that, thank you very much. Jangan lupa balik mengundi, yeah, and don't forget to fill up your attendance. And this is the QR code for the CPD points for the colleagues from the MOH hospitals as well as teaching hospitals who are actually joining us today. We will reward you the CPD points, so you can scan now and get your CPD right away. So with that, thank you very much, and we will we will paste here the QR code for you to be able to scan for at least 5 minutes. With that, thank you very much. Have a good day. Assalamualaikum warahmatullahi wabarakatuh. Thank you very much. See you next year. Jangan lupa mengundi. Bye. Assalamualaikum.